Welcome back to this ECG interpretation series. In part 3 we're going to be talking about conduction disease and bradyarrhythmias, so the slow arrhythmias. We'll briefly revise the normal physiology first. So, the action potential starts in the sinus node in the top right of the right atrium. From there it spreads through the atria down to the AV node. There it travels to the bundle of His, which splits into the right bundle branch and the left bundle branch, and you'll note that the left bundle branch splits into an anterior and posterior division, or fascicle. So it could be said that the electrical impulse enters the ventricles through three fascicles. Okay, the anterior and posterior divisions of the left bundle branch, and then the right bundle branch could be considered our third fascicle. Now I've created my own diagram that we're going to use throughout this talk. Here it is here, and it's all the same stuff. Sinus node, AV node, bundle of His, right and left bundle branches, and two fascicles here. With the normal physiology out of the way, let's talk about conduction disease. So, if the conduction disease is at the level of the AV node, well, that results in AV block. If the disease is at the level of the bundle branches, that results in bundle branch blocks. And if it affects the fascicles, then a fascicular block. And of course you can get combinations of all of these. But what if the first link in this chain, the sinus node, fails to fire? What if no electrical impulse arrives at all? Well, in that case you get what's called an escape rhythm, and we're going to talk about that first. The sinus node is not the only part of the heart which is capable of activating or depolarizing spontaneously. If the sinus node, for whatever reason, fails to depolarize, then some other part of the heart can take over, and then that will generate what's known as an escape rhythm. Or if it's just a single beat, then we'd call it an escape beat. Now, the more distal in that conduction pathway, the more distal the origin of this escape rhythm, the slower the rate will be. So the sinus node is usually the fastest, and that makes sense. By being the fastest to fire, it usually is in control of the heart, and that's why the normal rhythm is sinus rhythm, okay, because the sinus node is usually the fastest part to be depolarizing. So the intrinsic rate of the sinus node is about 70 to 80 beats per minute. The AV node is only 40 to 60 beats per minute. And the Purkinje fibers and the ventricles themselves, 15 to 40 beats per minute, so quite slow. So what you can see here in this ECG, okay, this is lead 2, you can see an upright P wave followed by a QRS. Alright, so that's probably a sinus P wave. If we go back to our first lecture, upright in lead 2, that's probably a sinus P wave. So this is a sinus beat overall. We've got another sinus beat here, upright P wave, QRS. But then we've got this long pause where the sinus node failed to fire. And after that, we have an escape beat. And you'll note there's no upright P wave preceding it, so this one did not originate from the sinus node. So both of these are actually junctional or AV nodal escape beats. On the last slide, I said we had two junctional escape beats. How do we know that those were junctional beats versus, say, an atrial beat or a ventricular escape beat? How did I know that they came from the AV node, okay, the junction? How do we identify the origin of any beat? Well, we've already talked about this in relation to sinus rhythm. Okay, we said if the sinus node is the first part of the heart to depolarize or to activate, we said that the P wave will be upright in lead 2 and inverted in AVR. Okay, those are our normal P waves. And if there's no conduction disease, well, then it will be followed by a normal QRS complex as it travels through the bundle of His and into the ventricles. And so by assessing the P wave and the QRS morphology, you can figure out where a beat originates from. So let's go through that in a little bit more detail. Sinus beats, as you know, normal P wave being upright in lead 2 and inverted in AVR, and then it conducts through the bundle of His into the ventricles, and you get a normal QRS complex, okay, a narrow QRS complex. Atrial beats, and by this we mean not sinus node, not AV node, so somewhere else in the atria. So for example, let's say somewhere up in the left atrial wall. If you have an atrial beat, well, there's going to be an abnormal P wave. You're not going to have the usual upright into inverted AVR pattern. You'll have some other pattern. So you have an abnormal P wave, such as this one here, okay? But once we hit the AV node and conduct through into the ventricles, well, all of this conduction is still normal. So you have an abnormal P wave followed by a normal QRS complex, and that tells you it's an atrial beat. There are a couple of different patterns that you can see with the junctional beats. The first is a normal QRS complex with an absent P wave. And if you think about what's happening, the junction, or the AV node, is firing, and then both the atria and the ventricles are being activated following that. So it's spreading both up and down from the AV node. And if that happens at pretty much the exact same time, well, the QRS will be sitting directly over top of the P wave and will completely obscure the P wave and you won't see it. Okay, so in that case, you get absent P waves and just a normal looking QRS complex like that there. Alternatively, if the action potential spreading upwards into the atria happens just before the activation of the ventricles, then you might see the hint of a P wave before the QRS complex. Okay, so that's what we've got here. And it should be an abnormal P wave. Okay, it won't be upright in 2 or inverted in AVR because it's moving in a totally different direction. Okay, it's moving upwards instead of down from the SA node. Alternatively, maybe the ventricles activate first and then the atria, and so in that case you might get the P wave just after the QRS complex. But the point is, in any case, when the junction, or the AV node, is the first thing to fire, you get a normal QRS complex with an abnormal P wave, and the P wave may be totally absent, it may be very close and just before the QRS complex, or just after the QRS complex. Those are the patterns you get with junctional beats. Finally, with ventricular beats, okay, so originating somewhere in the ventricular wall, well, these spread from muscle cell to muscle cell. They don't involve any of these normal conduction pathways. And for that reason, the action potential spreads very slowly, which means the QRS becomes wide on our recording. So if you see a wide QRS complex with no P wave preceding it, well, that would be a ventricular beat. Now that you know all of that, let's go back through an example. Upright P wave in lead 2, upright P wave, both of them followed by normal QRS complexes. This is our sinus rhythm pattern, so we have 2 sinus beats. Then we've got a QRS complex followed by a P wave. Okay, but this is a normal QRS complex, so this is a junctional beat. Again, normal QRS complex. This is probably an inverted P wave just before the QRS complex, so we've got 2 junctional beats. And as you can see by the large pause between these two, the AV node has a slower intrinsic rate than the sinus beats do. Moving on to heart block. Let's start by talking about disease of the AV node, AV block, heart block, 2 different names for the same thing. So conceptually, we divide this into first, second, and third degree heart block, and I want you to understand the concept here. In first degree AV block, or first degree heart block, every P wave makes it through the AV node and into the ventricles. In second degree heart block, only some of them do. So sometimes the atria fire, but it fails to conduct through to the ventricles, and then sometimes it does conduct through. So it's intermittent failure. In third degree heart block, or complete heart block, none of the P waves, okay, none of the atrial activity ever makes it through to the ventricles, and that's complete heart block. But now let's go through them one at a time. So as we just said, in first degree heart block, every P wave is conducted into the ventricles. The AV nodal disease means that this takes longer than usual, and so as a result, we get a prolonged PR interval. Okay, remember the PR interval is the time it takes from atrial activation, start of the P wave, to ventricular activation, start of the QRS complex. And our normal range is 120 to 200 milliseconds. So if the PR interval is greater than 200 milliseconds or longer than one big square, then we'd say there's a first degree heart block. And as you can see in this example, it's 220 milliseconds. In first degree heart block, the PR interval is constant. So the PR interval here is prolonged, but it's the same length as the next one, and the next one, and so on. In second degree heart block, we said that we have intermittent failure of conduction through the AV node. Now we divide this into two types, Mobitz 1 and Mobitz 2, second degree heart block. So I'm going to talk about Mobitz 1 first. So in Mobitz 1, the PR interval is prolonged, and it's not constant. It progressively lengthens, and then eventually we have a dropped beat. By that I mean we have a P wave that's not followed by a QRS complex. After that, the AV node sort of resets, and then the next P wave is followed by a shorter PR interval. So as we can see here, got a prolonged PR interval, and then even longer again. We went from 260 to 280 milliseconds, then longer again, and finally our last P wave is not followed by a QRS complex. But then it all resets, and so we have another prolonged PR interval, but shorter than where we've just come from. Then it lengthens again, and drops a beat. So these are the characteristics of Mobitz 1 second degree heart block. In Mobitz 2 second degree heart block, the PR interval is constant, but we still have these occasional non-conducted P waves, okay? P waves that are not followed by a QRS complex. Now this might occur in a fixed ratio, for example 2 to 1, so every second P wave isn't conducted, or it might be 3 to 1 or 4 to 1, or it could be variable, and it doesn't fit with a fixed ratio. And as you can see in the diagram in the example here, we've got a 2 to 1 Mobitz 2 heart block, where every second P wave is not followed by a QRS complex. In third degree heart block, or complete heart block, there's complete failure of conduction through the AV node and into the ventricles. The atria will continue to fire, the ventricles will continue to fire, but they will do this totally independent of each other, and so we describe that as complete AV dissociation. There will be no correlation between the P waves and the QRS complexes. What you might see on the ECG, you might see regular P waves. For example, that's what we have here, P wave followed by another P wave, P wave. These are occurring regularly. And then we've got regular QRS complexes. But you'll notice that they have different rates, and they're not at all related to each other. Now you won't always see regular P waves because sometimes they'll be obscured and hidden by the QRS complex itself. Moving on from heart block to bundle branch block, the electrical action potential has made it through the AV node into the ventricles, but now it's encountered a block in one of these pathways. Now this means that conduction through the ventricles will be slower than usual, and therefore the QRS will be wide. It'll be greater than 120 milliseconds or more than 3 small squares. Now as we mentioned back in the first lecture, that whenever you have a wide QRS complex, that will cause some secondary changes. So you might get T-wave inversion or other abnormal T-waves, and you might get ST segment abnormalities. Now to remember, the trick to remembering left versus right bundle branch blocks, a lot of people use William and Morrow. So if you can remember William and Morrow, the word is meant to help you identify whether it's a left or a right bundle branch. The first part of the word corresponds to V1, the last part of the word with V6. So if you have a W shape in V1 and an M shape in V6, where you've got 2 L's in the middle of William, so it's a left bundle branch block. On the other hand, if you've got an M shape in V1 and a W shape in V6, 2 R's in the middle of the word Morrow, so this is a right bundle branch block. You might find that helpful, or maybe not. In a left bundle branch block, you get deep S waves in V1 to 3, and this is where you're meant to get the W shape. You get a tall, notched R wave in V5 and 6, and this is your M shape from your William and Morrow. The ST segment and T waves will change, and they're usually in opposite directions to the QRS complex. So for example, we've got a negative QRS in V1, so we've got upright T waves and a small amount of ST elevation. Remembering back to the last lecture, this would be discordant. When we dance with discordance, this is appropriate discordance. The other feature of a left bundle branch block is left axis deviation. So usually with a left bundle branch block, you'll also get left axis deviation. Now, unfortunately, as you can see, the classic W and M shapes are pretty subtle. This doesn't look much like a W to me, and this only barely looks like an M. So really, you just need to learn these patterns. The deep S wave in V1 is probably the key, and the wide QRS complex. So here we have an example of a left bundle branch block, and you can see the wide QRS complex with the deep S waves in V1 and the notched R waves in V6, V5 and 6, which are meant to resemble your M shape. As you can see, William and Morrow is not always the most helpful to help you identify the bundle branch block. But what you hopefully didn't miss is the wide QRS complex and the deep S waves in V1, and that pattern is the easier way to recognize a left bundle branch block. I'll point out that in this case we actually don't have left axis deviation, but in a typical left bundle branch block you will have a leftward axis. In a right bundle branch block we get a different pattern. So it's classically described as this RSR complex in V1. So we've got two R waves, and the second R wave is labeled R prime, this little superscript 1 placed above it. So that's the shape you get in V6, RSR. And that second R wave is taller and wider than the first. Okay, we'll talk a bit more about that in a second. V6 has a QRS complex with a wide, slurred S wave. Alright, and this is meant to be a W shape. Okay, so M, W, Morrow. Hopefully that helps you to identify that this is a right bundle branch block. Now, as we said earlier, it's a bundle branch block that's going to be wide QRS greater than 120 milliseconds. And in a right bundle branch block, if that's the only problem, then there's not going to be any axis deviation. Okay, right bundle branch blocks usually have a normal axis. Now, to explain the next bit, it's important that we understand a bit about the pathophysiology of what's happening here. Because the right bundle branch is blocked, the right ventricle will depolarize after the left ventricle, and it will happen slowly, muscle fiber to muscle fiber. The left ventricle will still depolarize normally, won't it? Because it's still got a working left bundle branch. Okay, but the right ventricle will depolarize slowly. And the fact that it's depolarizing slowly is why the last part of our QRS is always described as slurred. Okay, we've got this wide slurred S wave, and you can even see this R prime, this second R wave, it's wider than the first R wave. Now the reason I want you to understand that is because if you're relying on William and Morrow, you don't always see this M and W shape that you'd be looking for. Particularly in people who've had an old anterior infarct, they may not have that first R wave. But because it's a right bundle branch block, they do still have that wide QRS complex, and the last part of the heart to depolarize occurs slowly. And so we've got this wide end of the QRS complex here. And to really prove that it's a right bundle branch block, you need to understand that V1 is a right-sided lead. So it's placed on the right side of the sternum. So if the right ventricle is the last thing to depolarize, then the last part of the QRS will be depolarizing towards V1, okay, towards the right because it's the right ventricle, and therefore the last part of the QRS complex will be upright. Okay? And hopefully you remember back to the R wave progression that we discussed in the first lecture. V1 is not usually upright at all. It's usually predominantly negative. So if you see a predominantly upright QRS in V1, that should already alert you to the possibility of a right bundle branch block. And then if you see this pattern, then you know it's a right bundle. And I would say this is a much more useful way of remembering right versus left bundle branch blocks than William and Morrow, because as you've seen by now, the M and W shape, they can be pretty subtle and they're not even always there. And here's an example of a right bundle branch block. As you can see, we've got wide QRS complexes, we've got RSR in V1, and this is meant to be our M shape. We've got a QRS with a wide slurred S wave in V6, and that's meant to be our W. And if you can be bothered calculating the axis, you'll notice that it's normal. Okay, and that's what you'd expect in a pure right bundle branch. So now let's talk about fascicular blocks. Now you'll remember that we said that you could think about it as the electrical activity enters the ventricles through three fascicles. So we've got the left anterior fascicle and the left posterior fascicle, and then we can consider the right bundle branch to be another fascicle. Now you can have an isolated left anterior fascicular block, okay? These isolated fascicular blocks are somewhat rare, but they do occur. The features are kind of subtle, and we're not going to go into very fine detail here. The QRS complex may be normal because so much of the conducting system is still intact, or it may be only slightly prolonged. Really, the giveaway is that they cause axis deviation. So if you have a left anterior fascicular block, you get a left axis deviation. If there's a left posterior fascicular block, you get a right axis deviation. Now that you've got the basics down, we're going to take things one step further and talk about combinations of these issues. So we're going to start by talking about bifascicular blocks. Think back to the slide on right bundle branch blocks. I mentioned on that slide that there should be a normal axis. If it's just a right bundle branch block, the axis will be normal. And then on the last slide I said that if one of the fascicles are blocked, then you'll get an axis deviation, okay? A left axis with the left anterior fascicular block, and a right axis with the left posterior fascicular block. So if you're looking at the ECG, and you see the RSR complex in V1, okay, so that's alerted you to the right bundle branch block, and you also see that there's an axis deviation, well now you suspect that in addition to your right bundle branch block, okay, you've also got one of the fascicles blocked. And depending on which way the axis is going, you know whether it's a left anterior fascicular block or a posterior fascicular block that's accompanying this right bundle branch block. Okay, and so you call that a bifascicular block, and depending on the axis, you know which fascicle is involved. So here we have an example. If you're looking at this ECG, I'm hoping that you've seen the wide QRS complex. Okay, you can see that there is a wide QRS complex. It's RSR. Okay, this is our M shape. So this is a right bundle branch block. And if we were to figure out our axis, well, lead 1 is positive, AVF is negative, lead 2 is also negative, so this is a left axis deviation. So we've got a right bundle branch block plus a left axis deviation. This is a bifascicular block involving the right bundle branch and the left anterior fascicle. So here it is on the diagram. These two fascicles are blocked. Okay, let's add one last detail, and let's talk about trifascicular block. Let's say you're looking at the ECG, and you've already identified the bifascicular block. Going through it step by step, you've already seen the RSR complex in V1, okay, and that's told you that there's a right bundle branch block. You've noticed that there's an axis deviation, and let's say that you've seen a left axis deviation, which means the left anterior fascicle of the left bundle branch is also blocked. So that means there's a bifascicular block, okay, following that far. Let's say after you've seen all that, you also notice some evidence of AV nodal block, okay, or heart block. Think about what's happening in this bifascicular block. All of the electrical activity from the atria are traveling down to the AV node and then through the bundle of His, and the only pathway left to them is this one remaining fascicle. So all of the electrical activity of the ventricles is going through this one fascicle. So if there is disease either in the AV node or somewhere in this one remaining fascicle, the PR interval is going to lengthen or change in some way. And you'll see that as heart block or AV block. So you've seen your RSR pattern, you've seen your left axis deviation, and then you notice there's a prolonged PR interval as well. Now you know your one remaining fascicle is also failing. Okay, so all three fascicles have disease in them. You call this trifascicular block. Let's see what it looks like on the ECG. Alright, we've got a wide QRS complex. We've got the RSR pattern in V1. Okay, so that alerts you to the right bundle branch block. Okay, the Morrow, the M shape for Morrow. You've also done your axis and you found positive in 1, negative in AVF, negative in lead 2. That's a left axis deviation. Alright, so we've got right bundle branch block plus left axis deviation. That makes it a bifascicular block involving the left anterior fascicle. Alright, so right bundle branch is gone, left anterior fascicle is gone. And now we look at the PR interval and we see, well, this P wave starts on the line, it's more than one big square. So we also have a prolonged PR interval, we have a first degree heart block, as well as the bifascicular block that we've just identified. So on this ECG we have a trifascicular block. Okay, and this is a pretty good example of why you really need to be systematic when you interpret the ECG. If you only saw one of these abnormalities, then you'd miss the fact that actually all 3 fascicles have disease in them. Okay, this is evidence of quite severe conduction disease. By now you've probably got a good understanding of cardiac conduction disease, and this talk really wouldn't be complete if we hadn't mentioned paced rhythms. So many of the patients who have such extensive conduction disease will go on to receive a pacemaker, and it's worth being able to identify paced rhythms on the ECG. Really, the key feature that you need to see is the pacing spikes, and those are these sharp little spikes just before the QRS complex on this ECG. Now it depends where you're pacing. If we're pacing the atria, then the pacing spike will occur before a P wave. If we're pacing the ventricles, the pacing spike will be followed by a QRS complex. But of course, we're not activating the usual bundle of His and bundle branches and the usual conducting system, so the QRS complex will be wide in a paced rhythm. And so that's what we see here. We've got 2 non-paced beats, okay, following the usual conducting pathways, and then from here on we've got pacing spikes followed by wide QRS complexes. This is the start of ventricular pacing from this point onwards. Well, I hope this talk has been helpful. I hope you have a better understanding of cardiac conduction disease. I'll see you in the next talk for a discussion of tachyarrhythmias.